Hello.
Hello. Good morning.
How are you doing?
Not too bad. How about yourself, Bruce?
I am doing okay.
I'm trying to unmute our participants. There we go. I think I got it. Well, it's just about 11:30, so I'd like to say good morning to everyone and thank you for joining us. This is Kelly Bader from the NPO. We are fortunate to have Bruce Mackey with us today on the phone and on the go-to to talk about MIPS and the ACO. So I'm just going to turn it right over to Bruce. Maybe can't hear you. Hold on a second, Bruce. Let me double check. All of a sudden, I can't hear you. I wasn't having technical difficulties. Okay, Bruce, I think I got it. Sorry about that.
All right. No problem. Are you able to hear me?
Yes, sir.
Okay. All right. Well, I'm getting some feedback.
Oh, I'm getting feedback as well.
Yeah, I can hear myself echoing through. Okay, there we go. That sounds better. Assuming you guys can still hear me. All right. Well, I think we have that all ironed out. Thank you, everybody, for giving me the opportunity to discuss the quality payment program, and most specifically talking about the 2018 MIPS rules and how they apply to the Medicare Shared Savings ACO members. The program changes quite a bit, and there's some very specific things that you guys need to be focusing on and working on. So I am here to kind of walk you through all those rules and kind of guide you along to make sure that you're working on those things that are most important, or that can not only affect you, but affects the ACO as well. Okay, so from a very high level, we've got the quality payment program. We've got these two tracks in the QPP. We've got the MIPS track, the merit-based incentive payment system, and then we also have the advanced APM track. And really, if you're in a Medicare Shared Savings ACO, a track 1 or 2, you're really kind of somewhere in the middle of these two tracks. And that's what I hope at the end of this presentation you'll have a good understanding of that really you're somewhere in between these two boxes. So on the one hand, we have the MIPS program, the Merit-Based Incentive Payment System. It combines multiple legacy Part B programs that you're probably familiar with or have been participating in for several years. It combines them into a single program. So we have the Medicare EHR Incentive Program, we've got the PQRS program, the Value-Based Modifier program. Those have all now sunsetted, those have gone away, and they've been combined into this new program called MIPS. Within MIPS then, we have 4 performance categories that participants are scored in. We have the quality category, which is really just the PQRS program, the former PQRS program kind of reworked. We've got the cost category, which is essentially the value-based modifier, or the cost side of the VBM program. We've got what is now called promoting interoperability. Last year, this performance category was called ACI, or Advancing Care Information. They've renamed it to PI, or Promoting Interoperability, and ultimately it's just Medicare Meaningful Use rescored. And then the fourth category, we've got improvement activities, or IA. So on the other track then, we have the alternative payment models.
It's still hard to
In APM is a generic term that describes a payment model in which providers take responsibility for cost and quality, and then they receive payments for services.
Hey, Bruce, could I interrupt for a moment?
Yeah, no problem.
I'm sorry. If I could just have everybody mute their phones, we're picking up a lot of external noise. So sorry, thanks. Go ahead.
No problem. So according to MACRA, which the QPP is a part of, APMs in general include a bunch of things, including the accountable care organizations. Really, any type of ACO is some sort of APM, including the Medicare. Okay, there we go. I got muted for a second there. So again, APMs include all the different ACOs, including the MSSP track ACOs. And I understand we've got 2 ACOs on the line here now, and both of those are track 1 ACOs. So the QPP does not change how those ACOs pay for medical care or reward the value. The QPP kind of adds additional incentives onto that existing ACO model. And then if you are in, if you're in an APM, you may receive some favorable scoring under the MIPS performance categories, and that's really the bullet that applies here to the ACOs on the line today. And because you are not an advanced APM, and only some APMs reach that status of it being an advanced APM. So at the very top of this pyramid, we've got those advanced APMs. They have the greatest risks. They offer the greatest potential rewards as well. In the middle, we've got these qualified medical homes, which are essentially, they have a different risk structure, but they're treated as advanced APMs in this program. And then we have those MIPS APMs, and that's where you guys fall in these ACOs. You are kind of bridging that gap between the MIPS track and the APM track of the QPP. You do receive some favorable MIPS scoring. There's some other great benefits to being in the ACO or being in that MIPS APM, but you are still required to participate in the MIPS track of the QPP. So that's where that kind of middle ground is at, that you guys find yourselves in. So the criteria to be in that MIPS APM, which is, in this case, we're calling it a non-advanced APM. You have to participate in that APM model, an agreement with CMS, which you're doing. The entity has to include at least one MIPS-eligible clinician on the participant list. That's an easy one to meet as well. And then payment incentives are based on performance on cost and quality measures. So the ACOs, the MSSP Track 1 and Track 2 ACOs fall under those criteria. And really, the vast majority of Medicare ACOs are Track 1 ACOs. So the advanced APM benefits don't apply. You do have to participate in MIPS to receive any favorable payment adjustments. And the flip side of that is you'd be penalized if you didn't participate in the MIPS track. You unfortunately don't qualify for the 5% APM bonus payments. That's kind of the main benefit for being in that advanced APM is you get a 5% lump sum bonus on your Medicare Part B billings. So you don't qualify for that. And you're also not eligible for those higher baseline annual fee schedule updates that are going to start in 2026. But there are some significant benefits to being in this MIPS APM. So one of which, although you do have to participate in the MIPS track, you receive full credit under the improvement activities performance category. So you don't have to participate in that. You're automatically getting full credit because you're in the ACO. The ACO is also responsible for the quality performance category reporting. So as a member of that MIPS APM, the ACO handles the quality reporting for you. You do, of course, get the shared savings and any other ACO-specific rewards that are built into that model. And then you are also then eligible for those annual MIPS bonuses, which continue indefinitely. That 5% lump sum bonus that the advanced APM folks are getting, that's going to end after 6 years. Whereas if you were in a MIPS APM, if you're in a Track 1 ACO, the MIPS bonuses, those incentives for doing really well in the MIPS program are going to continue indefinitely. So that's a great benefit to being in the ACO as well. So as you are working through this program in the MIPS track, what you're doing is trying to build the best MIPS final score that you possibly can. So that MIPS final score is a weighted combination of those 4 performance categories. In this kind of standard model, this is the weighting for regular MIPS participants. I'm providing this merely for context as we kind of build kind of what the QPP looks like for you guys. So for a regular MIPS participant, the quality category this year is worth 50% of that score, cost is worth 10%, improvement activities are worth 15%, and then promoting operability picks up the last 25%. But again, this is a little bit different for you guys. So because you're in the ACO, you fall under what's called the APM scoring standard. It's a little bit different weighting for those ACOs, or for these MIPS APMs. So under the APM scoring standard, offers a special, minimally burdensome way of participating in MIPS. So for those folks that are still in an APM and required to report for MIPS, just like you guys are. So it changes the weighting a little bit. In this model, under the APM scoring standard, and this is what applies to the ACO, quality is worth 50%, cost is worth 0%, improvement activities is worth 20%, and promoting operability is worth 30%. So it's the combination of these weights that get the ACO to the ACO's final score. So thus, as a responsible, conscientious member of the ACO, it's your duty to help the ACO get the best possible score. So in this way, you know, the old adage, a rising tide lifts all boats, applies here. As each of you individually do better in the MIPS program, everyone does better. So that's really the main tenet of an ACO. There's strength in numbers. So in this way, all the participants are going to receive, all participants in the ACO are going to receive that same MIPS final score. So across the ACO, you are seen as one massive group. So all of your data is going to get consolidated into one set of data, and that one set of quality scores, that one set of promoting interoperability scores are going to determine what the MIPS final score is going to be for the ACO, and then everybody in the ACO is going to get that MIPS final score. So again, it's your duty to do the best that you possibly can. So under quality, as I mentioned, the ACO is going to handle that. They're on the hook for doing that quality reporting for you. Cost being at 0, the reason it's at 0 is because you're already assessed on cost under the agreement with the ACO. So you're not assessed a second time under this model. That you get that full credit under improvement activities. So just being the ACO member, the ACO is automatically going to get those 20 points. And so it's the promoting interoperability piece that is most important at the TIN level. So in that category, each tax ID that is a member of the ACO has to group report their PI data. So then all of that PI data from each of those tax IDs gets rolled up into a consolidated PI score that then determines the ACO's MIPS final score. So here's the folks that are on the surface MIPS eligible. These are the clinicians that would be participating in the MIPS track. So we have physicians, PAs, NPs, CNSs, and CRNAs. This is proposed to expand next year. It appears as though they're going to pull physical therapists, occupational therapists, and clinical psychologists into this list. But for you, being that ACO member, this is useless information. This really means nothing to you because what you are responsible to report, which again comes down to really just that promoting interoperability data, that is going to include all providers for whom you have data in your EHR, whether they're on this list or not. So keep that in mind. So up here we have that it includes physicians. Physicians includes a whole bunch of doctors listed here. But again, this is useless information to you because when you group report your promoting interoperability data, that group report is going to include data on all clinicians for which you have data in your EHR. So it doesn't matter to you what provider type they are. You must include all data for any clinician for which you have data in your EHR. I'll go through that a little bit more as we kind of build the case here as well. So again, the PI category is what you are responsible to report on. This is the case for all tracks of the MSSPs. You have to group report at the TIN level. And it is, you aggregate that data by adding together all the numerators and denominators for each clinician within the group for whom you have data in that EHR. So again, that's all clinicians, not just those MIPS eligible clinicians. It's everybody. The group at the TIN level then submits one numerator and one denominator for each measure. So in this scenario, only the PI data for those clinicians using your EHR is aggregated and submitted. No PI data is submitted for those clinicians within the TIN who are not using the CERT. So if you have hospital-based clinicians or you have non-patient facing clinicians, they may not have data in your EHR, and on the surface there are exemptions for those folks, but really those exemptions for hospital-based and non-patient facing are somewhat moot when you are group reporting, because you just include the data for anyone who is charting in your EHR. And so if you're hospital-based clinicians, or if you have non-patient-facing clinicians who are not charting in your EHR, you just simply wouldn't include their data. So thus, there's no negative effect on the ACO's MIPS final score. There's a bunch of different ways that you can get that PI data to CMS. Each one of these performance categories have different options for getting the information to CMS. Really what you focus on here is not just what I have marked in the red box on this slide, but really it's under the group submission on the right-hand side. You can submit via attestation, which is references just logging into the QPP portal at qpp.cms.gov and manually attesting to your promoting interoperability information. We've got and by manually, you're going to be uploading some data there. We've got QCDRs, qualified registries, EHR references, the EHR on your behalf, your EHR vendor submitting that data, that PI data on your behalf to CMS. And then we have the CMS web interface as well. So if you're not sure what each of those means, I've got the data submission options are defined here. I'm not going to read through these for you. So now we're going to really dive into the promoting interoperability performance category, because again, as that ACO member, that's really the only performance category you're on the hook for reporting on your own. So I want to kind of dive in, do sort of a deep dive on what's required here in the PI category. So again, it's worth 30% of that final score. It is comprised of 3 different scores. We have the base score, a performance score, and then a bonus score. It focuses on certain measures around patient engagement and the electronic exchange of information. We've got a couple of measure sets that you can choose from, and I'll talk about those in just a moment as well. There is a 10% bonus if you are reporting, if you're using 2015 certified technology and you're reporting on just what we're calling the regular PI measures, and I'll show you what those are in a minute. But really, that bonus is only going to come into play if the entire ACO, if everybody in that ACO is reporting on just 2015 technology and using those regular PI measures. So I doubt that really any ACO is going to see this 10% bonus, because it's unlikely that everybody in the ACO, at least today, it's unlikely to imagine everyone in the ACO all being able to report on those regular PI measures. There are some exclusions for a couple of the measures, and I'll talk about those. And so let's dive in a little bit deeper into here. I talked about those exceptions that exist. Really, this applies mostly for the non-ACO members, though, because while there is some automatic reweighting that happens in this category for hospital-based clinicians or the nurse practitioners and PAs, and really that reweighting doesn't really apply at the, it really only applies if the entire TIN was hospital-based, or if the entire TIN had just nurse practitioners or PAs or CNSs. So because you're group reporting, these exceptions are looked at across the entire group. So while these clinicians don't necessarily need to report on PI, you're going to be capturing their data if it exists, as I mentioned a slide or two ago. So as we dive into a little bit deeper into the scoring, as I mentioned, we've got that base score, a performance score, and a bonus score. Then that equals your category scoring. So at the base score, that gives you half of your points right there. You earn 50 points for just meeting that base score, and I'll talk about on the next slide what that means. We've got the performance score, which then looks at your actual performance across all of the different PI measures, and you can get up to an additional 90 points there. We've got some bonus points that are available. All of that goes together to earn you the category score. And if you earn 100 points or more in that performance category, you're going to contribute the full, this says 25 points, I need to change that to 30 points in the promoting interoperability category. Because again, 25 points references the normal MIPS track. The 30 points would indicate the APM scoring standard. So you've got that base score. In the base score, this is really the only place where we have sort of an all or nothing component to the category. In order to earn the base score, or really to earn any PI score, you have to achieve your base score. If you can't achieve the base, you are going to be contributing zeros to the consolidated PI score, which you most definitely don't want to do. So I'm referencing again that there are two different measure sets that you can choose to report on this year. We had these same options available to us last year, and they carry forward again to this year. We have the 2018 transition objectives, which correlate back to the modified stage 2 of meaningful use measures. And then we have what I've kind of called in quotes the regular objectives, the regular PI objectives. These require that you must be on 2015 certified technology in order to achieve these measures. These correlate to the stage 3 objectives of meaningful use. But you have your choice here, regardless of which technology you're on, whether you're on 2015 technology or not. You can choose between these. So if you're on 2015, you can still use those transition objectives. If you're still on your 2014 version of your technology, of your EHR, you can only report on those transition objectives. So in the base score, you have to do one of everything. So for these 4 measures on the transition side, or 5 measures on the regular side, you have to do one electronic prescription. Because you are group reporting, that isn't each clinician needs to do one. You have to do one across the whole group. Same thing with the health information exchange. You need to, across the entire group of clinicians under your TIN, one of them has to send the health summary of care electronically. You can also, if you qualify for the exclusion, which I'll touch on in just a minute, you can get around that one. Same thing with the ERX, although we rarely see practices needing to claim the exclusion on ERX these days. Each TIN has to do a security risk assessment or security risk analysis every year, and then you have to provide patient access to a single patient. That is measure 1 of the patient portal objective. So that's where you are just offering your patient portal to your patients. Within the TIN, a single unique patient needs to be provided access to the patient portal. That would satisfy the base score. And so backing up, I wanted to make one other point there. More than one electronic prescription in the reporting period does nothing to improve your PI score. Because we only see the ERX measure appear in the base measures, not in the performance measures, you truly, in terms of the MIPS track anyway, you only have to do a single ERX in your performance period in order to get the points here. Doing more than that, because that one measure doesn't appear in the performance measures, doesn't buy you any additional points. It doesn't get you any further in the MIPS track. So really, the message there is concentrate on the improvement efforts where you can where it actually makes a difference. ERX is not it. So looking at the transition objectives under the performance score, then every numerator counts. So regardless of there are no thresholds like we saw in the meaningful use measures, where you either met this threshold or you failed that measure. It doesn't work that way under promoting interoperability and under MIPS. You need to do the best you can on every one of these measures to the point where you are maximizing the points. So again, depending on how many patients you are providing patient access to the patient portal, you had to do one to get that base score. But then the performance score really looks at that numerator and denominator. And if you have offered your patient portal to every one of your patients seen in the reporting period, you're going to get the full 20 points. If you only offered it to half of those patients, you would get 10 points. That's one of the measures that is worth 20 points on the transition objectives. Health information exchange is the other one that's worth 20. Again, that's one of the measures they're really trying to promote in this program. So while you needed to do one across the group to be able to get that base score, if you're one of those clinics that has been able to do well in this, of which I will state there are not many, that is it's a very hard measure to score well in. If you do send every single one of your summaries of care electronically, you can score 20 points there. Same thing with those other measures, although they're capped at 10. The better you do under each one of these measures, the more numerators you're going to contribute against that denominator, and you're going to score better and better. So here's how you calculate that performance within each one of those measures. You take the numerator and denominator and turn it into a percentage. If it is a yes/no answer, you're either at 0 or at 10 points. So if it's one of them, like if you answered yes to reporting to a public health agency, then you'd get those 10 points for that measure. Most of them, you convert them into a performance score, and then depending on that performance rate, you can see how many points they're going to get. For instance, on the patient-specific education measure, if you had 100 patients and you provided that patient-specific education to 85 of them, that would give you a performance rate of 85%, and then they would earn 9 out of the 10 percentage points for that measure. So we're going to dive into each one of the objectives or the measures within PI then. We'll talk about each one of these individually. So we have the protect patient health information or the security risk analysis measure. So there's no getting around this, folks. Every single year, you have to either conduct or review a security risk analysis. You don't always have to do a brand new one every year. If you've changed technology throughout the year, you'd have to do a new one. But lacking any significant technology changes from one year to the next, you could look at last year's SRA, ensure that you have been working all year long on fixing any issues that were identified in last year's, make sure that there are no additional new problem areas, sign off on that SRA, and that could suffice for this year's SRA as well. But again, if you've had any major technology changes, you're going to need to redo a security risk analysis. It is one of them that's a yes/no measure. You have to say that you did conduct or review your SRA and implemented security updates and corrected any identified security deficiencies. It is part of that base score, but it is not part of the performance score, and there's no bonus score that's attached to this one. E-prescribing, as I mentioned already, this one is in the base score, but is not in the performance score. So as a base score only measure, you need at least one permissible prescription written by the MIPS eligible clinician or the group is queried for a drug formulary and transmitted electronically using CERT. This is low-hanging fruit. Rarely do we see providers that are not doing this at all. So this is a fairly easy one to achieve. That numerator being the number of prescriptions in the denominator then that are queried for a drug formulary and transmitted electronically using CERT. But again, as long as the group does one, that's all you have to do in terms of the MIPS program. I would not advise, as long as you're meeting that base score requirement, I wouldn't advise sinking a lot of time and effort into pushing your providers to do more and more electronic prescriptions. It's great for patient care, but in terms of the MIPS program, what we're talking about today, it's not going to buy you any additional points to do more than just one in the reporting period. Health information exchange is a different story. While this one is in the base score, it is also part of the performance score as well. So this is a very difficult measure to do well in. This one is the health information exchange as a PI transition measure. It's called Send Summary of Care under the regular PI measures. Again, this is the one where you are electronically sending those summaries of care to the next provider of care. There is an exclusion, so any MIPS eligible clinician, or in this instance, if there's a group who transfers a patient to another setting or refers a patient fewer than 100 times during the performance period, you could claim the exclusion. I wouldn't advise doing that if you don't have to. I recognize that there are 1,001 barriers to doing well in this particular measure. If you can do one, I would advise doing that one to get that base score. Hopefully you're one of those practices that has been able to overcome a lot of those barriers and are able to score relatively well under this measure. But if you are, congrats to you. You're one of the few out there that are doing well in this measure. It is very difficult for a variety of reasons to get this up and running, not only with your technology, but then to find providers who you can send those summaries of care to electronically. It is just by far the hardest measure to score well in. But the more you do, the better you do. This is one of those measures that under the transition objectives is worth 20%. So you could, if you're doing well in this measure, you could get a whole lot of points for it as well. Patient electronic access. This is the patient-specific education measure under this objective. Under this one, the clinician or group is using clinically relevant information from your technology to identify patient-specific educational resources and then providing those resources to at least one unique patient seen by the MIPS eligible clinician. So here this one is not part of that base score, but it is part of the performance score. So if you don't do this at all, you just will get 0 points for that measure, and you can possibly pick up those points elsewhere. But the better you do on this one, you can earn up to 10 points in that performance score. So again, this one is often sort of low-hanging fruit. We see a lot of providers scoring pretty well in this measure, and it's a good way to get some of those PI category points by ensuring that you are letting the EHR kind of guide you in what education is important or should be provided to this patient. So also under patient electronic access, we have the provide patient access measure. This is one of the patient portal measures. So under this measure, at least one patient seen by the clinician or group is provided that timely access to view, download, or transmit their information. So this one is part of the base score, and it's also part of that performance score. So you have to do at least one. You have to offer your patient portal to at least one unique patient seen by the group over that performance period. But the more patients you provide access to, the more patients you give them that login information to create a patient portal account, the better you're going to do under this measure. And you can, again, this is the other measure that on the transition side is worth up to an additional 20% of that score. So this is the other patient portal measure then. This is the VDT measure, view, download, and transmit measure. Here, this one is not part of the base score, but it's part of that performance score. This is where you're getting points for as patients are using your patient portal. So you're sort of on the hook for your patient behavior here, but the more patients you can coax into using your patient portal, the better you're going to do on this particular performance measure. So the denominator is the number of unique patients that are seen by the group during that performance period, and the numerator is then the number of unique patients that have actually accessed their portal and have done something in the portal, whether it's just viewed their information or they've downloaded it or they've transmitted it. Really, as soon as they log into the patient portal, you're going to get numerator credit for them here. So while you're sort of on the hook here, you're at the mercy of your patient behavior on this one. There are certainly some things you can do to coax your patients into using the patient portal. One way is through the secure electronic messaging, which I'll get to in a slide or two. The more you use the secure electronic messaging function of your patient portal, the better you'll do on this VDT measure as well, because patients would be logging into the patient portal to retrieve that message, which would then give you that numerator credit on the VDT measure. MedRec is another one of the PI measures. It is, again, we see this one being relatively low-hanging fruit. Medication reconciliation is just something that the vast majority of providers do on all of their patients, which is to me, just good patient care. So we see providers often scoring very well on this measure. The denominator is the number of transitions of care or referrals during the performance period for which the clinician or group was the recipient of a transition of care, or if it's just a new patient. If it's a new patient to the group, they would be counted in the denominator. And then the numerator is any of those folks that you've done MedRec on. Again, it is not part of the base score, so if you don't do any of these, you don't get harmed, you don't get a 0 on the performance category, you just wouldn't earn anything for this particular measure, but you can earn up to 10 points in the performance score on it. So secure and electronic messaging, as I just mentioned, this is a way that you can kind of coax your patients to be logging into the portal, which is going to give you that credit on the VDT measure. But under this particular measure, secure electronic messaging, you are sending messages through your patient portal, a secure message to the unique patients, and then the more messages you send, the better you're going to do on this measure. So again, this is a great way to get those patients to use that patient portal, because that is how they would access that secure electronic message that you've sent. So it's kind of 2 birds, 1 stone. You get a numerator credit for sending one of your patients a secure electronic message, and then when they retrieve that message, they're going to log into the portal, which is going to trigger the numerator for the VDT measure as well. So again, this one is not part of that base score, but it is worth up to 10 points on the performance side. Public health reporting. This is one of the yes-no measures, so there's no numerator and denominator. There are a few different ways that you can get points here under the public health reporting. Under this objective, one of the measures is the immunization registry reporting. So if you are actively engaged with MICR here in Michigan to connect your EHR directly to the MICR system, you'd be able to attest yes to this one. I'll talk about what active engagement is in a minute as well. So again, this one is not part of that base score, but if you are reporting to any public health registry, you're going to earn the 10 points in the performance score. There is a bonus eligible here. So you earn 10 points for your first public health registry that you're actively engaged with. If you are engaged with an additional public health agency, you would earn a 5% bonus here. So active engagement can be achieved in a few different ways. You don't have to be in full production, which is option 3, where you are fully integrated with that registry and you're actively submitting production data to the registry. There are options 1 and 2 available as well. So under option 1, of active engagement, you have registered with that registry or that public health agency within the first 60 days of your reporting period, and the EC or group is just awaiting an invitation from that agency to begin testing and validation. So as long as you have started the process within the first 60 days, you are deemed actively engaged, and that's truly all that you have to do in terms of attesting yes to that measure under MIPS. A lot of folks are sitting in option 2 for a very long time while their vendor is working out the kinks, or you're working on that message back to that electronic message back to the registry. So as long as you are somewhere in that testing and validation process where you're working with your vendor and you're working with the public health agency to kind of figure out the message and get that integration completed, that is also actively engaged. And if you've gotten all the way to production, where you've gotten through the whole process and that interface is live and working well, that would be option 3. So a lot of different options to kind of define that active engagement, and as long as you are actively engaged, you can attest to meeting that measure. So we'll look at the other measures as well that all fall under the public health reporting objective. Again, none of these are in the base score. So you don't have to do any public health reporting. It's not required under the MIPS program. So if you're not actively engaged with any public health agency, that's okay. You could actually still earn the maximum points under the PI category by picking up points in the other categories. You don't have to do any public health reporting in MIPS. If you are, it's a good way to earn those points. A lot of folks have were forced to onboard with some agencies or some registries to meet the meaningful use requirements. That is a requirement under meaningful use, but under MIPS, currently anyway, it's not a requirement. So it's not required on the base score, but they are a good way to get those performance points. Syndromic surveillance reporting is only an option in Michigan for urgent cares and hospitals. So if you're not one of those, you would not be able to onboard with the syndromic surveillance program here in Michigan. You might instead find yourself looking to the specialized registry reporting. That is the third option under the public health reporting objective, where you are actively engaged to submit data to a specialized registry. Just like the IMS registry, the reporting requirements are the same. It is also a yes/no. If you can attest yes, you get those 10 points for any single registry. If you are engaged with MICR, you get the 10 points there. If you're engaged with a specialized registry as well as a second registry, you would get the 5 points under the bonus score. There are quite a few options for specialized registries here in the state of Michigan. I have them listed on this slide. So we've got MICR is a public health reporting measure. The syndromic surveillance I had listed, we just talked about, only be an option for urgent cares and hospitals. Then we have a bunch of specialized registry options like the cancer surveillance program, the birth defects registry, Michigan dental registry or MITRE. We have the MAPS program. I know here at MCETA we are pointing a lot of folks toward the MAPS program this year. They have started to integrate with EHRs through some funding that they're getting from the state and from Blue Cross. So it's a good way to get onboarded with them, and it's going to count as a specialized registry. And then we have the MDSS, the Michigan Disease Surveillance System. So a lot of different options for specialized registries at the state of Michigan level. So that's all of the transition objectives. I know there are folks that are planning to report on the regular PI objectives. So there's some additional measures there, one of which is the request and accept summary of care. So there's the regular send summary of care measure. That still exists under the regular PI measures as well. But then there's also a request accept measure. So under this additional regular PI measure, if you're working towards those, let's call them stage 3 measures, here for at least one transition of care or referral received or a patient encounter in which the MIPS clinician has never before encountered the patient, that clinician or group receives or retrieves and incorporates into the patient's record an electronic summary of care document. So it's not only are you sending those summaries of care documents to that next provider of care, you are also requesting them from those sending providers, and then accepting them and bringing them into your EHR. There is an exclusion on this one as well, because this one is part of that base score, meaning if you are moving, if you're using those stage 3 measures, this is part of that base. You have to do at least one of these in the reporting period unless you meet the criteria for the exclusion, with transitioning fewer than 100 patients out of your, or I'm sorry, in this one it's the receiving the patients. If you've received fewer than 100 transitions of care or new patients in the reporting period, you could claim the exclusion on that one. So again, under those regular PI measures, this is part of that base score. It is also part of that performance score, so the more of these you do, the better you can get. And again, there is that one-time bonus of 10%, but again, this likely isn't going to apply at the group level here, because the entire ACO would have to be reporting on the regular measures, and everybody would have to be on 2015 technology for that bonus to apply. Clinical information reconciliation is the second additional regular PI measure. In this one, it kind of takes the medication reconciliation measure and expands upon that. Under this measure, you're not just doing medication reconciliation, but you also are reconciling medication allergy and the current problem list. So you're looking at those known medication allergies and reconciling that past information with your information, and same thing with the current problem list. So you reconcile those 3 data points, and you'd get numerator credit here. Again, this one is not part of the base score, but the more of that information reconciliation that you do, you can earn up to 10 points here, and it's the same bonus score. You can get that bonus, but again, at the ACO level, it's we're unlikely to see that, at least not today. The third additional measure then is the coordination of care through patient engagement. It's incorporating patient-generated health data. So patient-generated health data or data from a non-clinical setting is incorporated into the certified EHR record technology for at least one unique patient seen by the MIPS eligible clinician during the reporting period. So again, the denominator here is the total number of unique patients seen by the group, the numerator being how many of those you actually did. It is not part of that base score, so you don't have to do anything in this one to earn a PI category score. But the more of them you do, the better you are off. The more numerators you're going to contribute to that to the top. And again, that bonus score doesn't really apply. So now we're going to take a look at what I would call a mediocre performer, a decent performer in this category. This is somebody who would be meeting meaningful use, but they're sort of a mediocre meaningful user, doing okay. So kind of tying it all together, we look at those base PI category score. Again, this is looking at just the transition objectives, not the regular objectives, which is why you only see the 4 base measures and not the additional ones that are under the regular measure set. So in this fictitious provider, or I guess we could call it a group here. In this group, they are doing very, very well on the ERX measure. They only needed to do 1 to get the base score. They provided their patient portal to the vast majority of their patients, only missed 3. They did okay they're doing relatively well in performance on the HIE measure, but again, for the base, they only needed to do 1, and then they completed their SRA, so they were able to attest yes to completing their security risk analysis for this year. So they got their total base score of 50%. So here it's either 0 or 50%. It's all or nothing. Now we look at the performance score. So here we circle back to the HIE measure where they only had to do 1 in order to achieve the base score, but this is one of those measures that's also a performance measure. So the better you do, the more points you get. This is worth up to 20 points. They did okay on this one. They were able to send 25% of those summaries of care electronically, which earned them 6 points on that measure. VDT access, this is the measure 1 of the VDT measure, where you're just offering the patient portal to folks. Relatively low-hanging fruit. We see the vast majority of practices doing very well on this measure. That's just they've got their receptionist just offering that patient portal to all of their patients. So in this fictitious group, they got a perfect score. Since they only failed to offer it to 3 patients, they got the full 20%. VDT usage, they are doing pretty well. Almost half of their patients are using the portal, so they got half of those points at 5. Patient education, another low-hanging fruit one we typically see, they earn the full 10 points. MedRec, another one where they're getting the full 10 points. Secure messaging, they didn't do so well. They only securely messaged 31 of their 432 patients. That translated to only 1 point on that measure. And then they attested yes to being actively engaged with 1 public health agency. So they got the full 10 points there. So out of a total performance score possible of 90 points, they got a 62. So here they've left roughly a third of the performance score points on the table. They got just over a third of them, leaving quite a few behind. So then we look at the bonus measures. They did attest yes to reporting to an additional public health agency, so they got the 5 points there, but they didn't get the bonus that exists for some specific IA category. So I didn't touch on that because it's not going to be relevant to you guys, because you automatically get full credit under the improvement activities, so you wouldn't necessarily be reporting any of those additional activities anyway. So in this group also, they are not getting that bonus that exists. So pulling it all together, we got the 50% base score, 62 out of a possible 90 on performance, and they got a few bonus points, which we find the bonus points are often not needed for a max PI score. There's 155 points available under this category, but as soon as you hit 100, you're capped. You've done all that you can do, and so you're going to contribute the maximum PI points. In this group, this fictitious group, assuming they were also in an ACO, would have contributed the max that they could to the PI points. So this is your obligation. This is what you need to be working towards. You need to be kind of using that built-in flexibility to concentrate on the areas that you can more easily maximize. With 155 available points, but full points earned at 100 points, a mediocre meaningful user could still earn that full category credit. And again, that's your obligation. If you're not contributing numbers that earn that max PI score for your group, you're not doing enough as a member of your ACO, and your shortfall could be hurting the financial performance of the entire ACO. So to put it bluntly, if you're holding the ACO back, they may, and in my opinion, probably should kick you out. I mean, that's the whole rising tide, raises all boats. Everybody in the ACO needs to be doing everything that they can be to ensure that they are maximizing the points here. Because the better all of you do, the better that ACO level PI score is going to be. So if you're kind of sandbagging it and doing the absolute minimum and just getting by, where if you're only concentrating on that base score, where you're just doing that one of everything so that you can contribute some points, that's not enough, because you're not contributing enough numerators to that group, to the grouped numerator score for each one of those measures. So you need to be doing the best you can. And if you are not contributing at least 100 points to that PI score, you're not doing enough. You're not being a responsible ACO member. So in that regard, if you are struggling to understand how you can do better, if you're struggling to maximize and if you're struggling to contribute those max points, you don't have to struggle on your own. There is free technical assistance to everybody who needs it here. So CMS is funding us through Altarum to be out there helping you. The upper right-hand corner here, the small and solo practices, the SIRS program, that's what we here at Altarum are here supporting you in. If you are in a small practice or if you're a solo practitioner, so if you have 15 or fewer billing clinicians under your tax ID, you can get free assistance through us. That website down at the bottom there, the qppresourcecenter.org. You can click the Join Now button if you haven't already gotten to us through this. I highly recommend it. There's some valuable resources there. We can kind of help guide you and work with you. You can pummel us with questions to help you understand. We can kind of guide you through some of those activities under the PI category and ensure that you're doing everything that you can be to be maximizing those points under PI. If you are in a large practice, contact me anyway. The organization that is assisting the large practices here in Michigan is MPRO. I would be happy to put you in touch with Holly over there, who I work with on a regular basis. They are being funded by CMS to support the large practices. We're being funded by CMS to support the small practices. But overall, there is free help to anybody who needs it in this program. So if you need that assistance, just reach out to me. You can go through the QPP Resource Center, and my colleagues will guide you. Whether if we can't take care of you, we'll point you to MPRO who can. You can also ping me directly at my email or give me a call as well, and I can kind of help guide you through it as well. So I think we have plenty of time for questions. I see the little chat box lit up, but I haven't been able to look at it yet. But we can open up the floor to any questions that we might have.
Okay, I do have a few that I've been holding on as the chat box has been scrolling. So the first one is, if a hospital-based physician uses the hospital EMR system and is in the ACO, how can they meet the base score?
So a hospital-based clinician on their own don't have to meet that base score. It's the entire 10 that would be scoring. So in this way, so as if that hospital-based clinician was not in the ACO and they were reporting at the individual level, they wouldn't necessarily have to participate in that PI category because they would be automatically reweighted. But that reweighting at the group level looks at the entire group. So again, as I mentioned, when you're consolidating all that PI data across your entire 10. So you are reporting, you run a practice level MIPS dashboard report, and you're adding up all those numerators and all those denominators for all your clinicians. So if you have a hospital-based clinician that is not using their EHR, or perhaps they're using the hospital-based EHR and you guys don't have access to it or whatever, that's not an ambulatory EHR. So we're really just focusing on those ambulatory sites, those ambulatory EHRs. And if your hospital-based clinician is not charting in your EHR, meaning they're not contributing numerators and denominators, then their data is just not included in that 10-level report that you're on the hook to report to CMS. Does that make sense?
Yeah, I think so. Next question. Under the bonus points, will the National Healthcare Registry count because that's easy points?
The National Healthcare Registry does count as a specialized registry. So if you're actively engaged with them, yes, if that's your only registry, that would count for that first single registry. And then if it's a second registry, if you find yourself already actively engaged with MICR, and then you're also participating with that registry, that would earn the 5% bonus points.
Okay, and it looks like, kind of segueing off that, for the public registries, do we have to have an interface electronically with them in order to take credit, or just be using their data via a website and uploading a report to our EMR?
So it's very specifically, you have to be actively engaged for that electronic submission. So the only registries that would count would be those that are able to interface with your EHR. So it may not work if you're just uploading that information, or if you're manually inputting that data, if you're logging into a website and and providing data manually, that's not going to count. It can count if you're extracting a report from your EHR and then uploading it directly, so there's no manual manipulation of that data. That can count as well, but you need to be careful with those. Really, the ones that are kind of cut and dried are the ones there's some sort of interface that goes directly from their registry to your EHR. Those ones are clear cut. Those ones are going to count. You don't have to be all the way into production status with that registry. You just have to be somewhere in the process of onboarding with that registry to submit that data electronically. But be wary of using the ones where there's any manual manipulation, if there's no actual interface. Again, it can still count as long as there's no manipulation of that data, or there's no human that is keying in that data. If it's a file that you're downloading and then uploading right to the website, those ones can count, but be careful of counting those ones.
Okay. MAPS is not listed on the HSTR site as a valid registry, aka it's not listed as a public health system, excuse me, that we can sign up for. How do we sign up for that? And there's no technical guide on the state of Michigan. I actually think I can share a website that I have for that.
Okay, yeah, I was just going to say I can send you the link if you don't already have it to send out to all the participants. So the MAPS program is a specialized registry, and it is one of the state's specialized registries. But LARA, the governing body, has opted not to get it pulled into the HISTR program, into the ST. We call it HISTR here.
Yeah. Okay.
They opted not to onboard with HISTR. I'm not exactly sure why. They decided they wanted to manage that on their own. So while it doesn't appear in the HISTR, it is one of the state's registries, and it does count as a specialized registry here in Michigan. So as you just said, you can send out a link. I'm happy to provide that as well if you want to ping me. But I can send you to the link on the LARA website. That there's a quick form that you fill out to kind of start that integration process. And so when you submit that form to begin that onboarding, that puts you immediately into that option 1, where you've registered within that first 60 days. And then the MAPS program, they actually won't work with you to onboard. They're going to work directly with your vendor, and they work with the vendor to work out all the messaging and everything. So you're kind of left out in the cold. Once you register, you're just kind of waiting for you to be live on the production side. But yes, that absolutely does count this year.
Okay, let's see. Got lots of questions. For reporting on all providers, not just those listed as eligible, such as audiologists, we also need to be measuring all these things on them as well to get one score for the practice. I think that's sort of a yes or no question.
Yes. So ignore the MIPS eligible ECs. For when you are generating that dashboard report for the PI category, it needs to include data on all clinicians for whom you have data in your EHR. So I think a lot of folks missed that very important point last year and maybe only ran those reports on those MDs and DOs and NPs, those folks that are listed as MIPS eligible ECs. But the rule states it's really QPP eligible ECs, which is really all clinicians, because everyone can participate in the QPP. There's only those 5 provider types that can participate in the MIPS program. But when you are group level reporting, you must include all data on all clinicians if they're charting in the EHR. So yes, that would include all those folks that individually can't participate to get an incentive in the MIPS program. So their data is used to generate the MIPS final score, but then they don't get any of the financial benefits based on that data, unfortunately.
And are clinicians who are new in 2018 part of those that need to be considered for the measures, or do they get some kind of pass for the first year?
You're still going to capture their data because again, if they're charting in your EHR, it's an umbrella. You have to grab that data from all clinicians who are charting in your EHR. but they don't qualify in the first year if they just got credentialed to bill Medicare in 2018. They will not receive the incentive that is generated based off of their data. They would just like those non-ECs, those audiologists and folks that are not part of the MIPS EC list. They too would be excluded from getting any financial benefits, even though their data is being used to generate your PI score.
And it says, not all providers are QPP eligible, like PEDS, RH clinics. You had mentioned that all QPP eligible providers must be included. So how do we include the PEDS and RHC providers that are not listed in QPP?
So every clinician, every provider is QPP eligible. So if you think of the QPP as being both that MIPS track and the APM track, all clinicians can be in an APM. There's no exclusions there for the ACOs. So it blankets everybody. So again, you include in your PI category submission, you include all data on all clinicians for whom there's data in the EHR. So don't pay attention to provider type. Don't pay attention to whether they're a MIPS eligible clinician or not. If their data is in your EHR, it must be included.
If we begin to get MAPS integration now, would it qualify for this year? I'm assuming as a registry.
Yep. So yes. So it just, you have to be careful of what your 90-day reporting period is. So I didn't mention this, probably should have. It is a minimum 90-day reporting period for your PI data. That you can extend that to be as long a reporting period as you want, up to a full calendar year. You can move that, it's your choice at the TIN level what that 90-day reporting period is going to be. So if you're only going to use 90 days and you haven't started to onboard with MAPS until now, until Q4, you want to ensure that your 90-day reporting period is Q4. Because if you just started reporting MAPS, or you started that onboarding process today, but you were going to use like January 1st through March 31st as your reporting period, you would be in violation. You wouldn't be able to attest yes, because you didn't start the process within 60 days of your reporting period. So yes, you can start that process today and have it count for that public health measure for this year, but just make sure that your reporting period that you choose doesn't cause you to violate that particular measure. And again, picking that 90-day reporting period, it might be more advantageous for you to report on 100 days or 150 days or maybe 365 days of data. You want to pick that reporting period in a way that maximizes that PI category points. You might maximize that category for your TIN at the 90-day mark. You might find by generating different dashboards that, hey, I found out that using this particular 150 days is what gets us to that point where we're maximizing those PI points. So you have to kind of manipulate those reporting periods. But again, make sure that any of them that require that timing, like onboarding with MAPS, would require you to have at least started that process within the first 60 days. Make sure that whatever performance period you choose, that you're not inadvertently violating that particular measure.
And there's a final question, or so far, I haven't seen anybody else put one in. It says, under the MAPS integration, what does that look like? Our legal department will not allow the score to be brought into the EHR, so is integration bringing back the score? I can speak to eClinical, to the person who's asking. It doesn't bring back the score. It's a single sign-on into Lara so that they rate directly into the patient, so they don't have to sign into another website and, then go search for that patient. So I don't know, Bruce, if you've had any other, if you've seen it functioning in any other software and have anything to add to that.
No, I honestly, I haven't seen the MAPS integration in person yet, so I don't know exactly what it looks like when you are fully integrated with MAPS. My understanding is that it is such that when you go to write a script, when you're doing that ERX, it's going to immediately ping the MAPS database in the background, and will somehow inform you writing your EHR. It'll give you that MAPS data somehow. I don't know how it's displayed in the EHR though, because I haven't seen it live yet.
I know, and in clinical, it's an informational screen. You don't save that data, so.
Yeah,
I would
my
think
understanding
it's pretty consistent.
I don't think it actually updates your patient record. I think it just triggers those some screens to pop to if you have a drug seeker and you're about to give them a narcotic, I think something's gonna pop on your screen to alert you to the fact that this patient is drug seeking.
I got a couple more questions.
Okay.
For 2015 cert, you said there's an additional points available. What if the entire ACO isn't on 2015 cert?
Yeah, so that's where you can get there's that bonus in there, that 10% bonus for clinicians or groups who are on 2015 cert and are reporting on those regular PI measures. But because you are a super group, we'll call it, you're being assessed at the group level, which is at the ACO level here. I believe the way that bonus would work is the entire ACO would have to, every single TIN would have to be reporting on 2015 technology and reporting on those regular PI measures instead of the transition measures. So if that's the case, if every single TIN in the ACO reports on 2015 technology and the regular measures, then I think the ACO would earn those 10%, those 10 bonus points. But if that isn't happening, if it's not the entire TIN that's being able to do that, I don't believe the ACO could get those bonus points, even if there are individual TINs within the ACO that are able to achieve that. We need every single TIN to be able to achieve it for the ACO to get those bonus points.
And I think I have another question. We're going to probably have to make this our last question because we're really taking up quite a bit of Bruce's time today. So if my EHR is 2015 cert, can we still choose to use the transitional measures?
Yes, definitely. You've got that choice this year. I will just state that you must be on 2015 technology next year. So if you're not already upgraded, you need to be working with your vendor to ensure that they've got you up and running for next year. You have to be on 2015 technology last year, or for next year. You can still be on 2014 this year. However, if you are on 2015 this year in 2018, you can choose which measure set to use. You are not forced into the regular measures just because you're on 2015 technology. You can still, this year anyway, have the option of using those transition measures regardless of your technology.
Well, I did have a few more questions, but like I said, we've used up quite a bit of Bruce's time today. I can't thank you enough, Bruce, for this great presentation and taking your time to spend it with us. We'll be sending out the slides, and there will be a recording available. Thank you for everyone who attended. Sure, go ahead, Bruce.
I was just going to say, for any of those additional questions, if you want to just email those to me, I'd be happy to answer them via email.
Great. I will do that. I'll make sure that Bruce gets the last few questions that are hanging out here, team. All right. Thanks so much, everyone. Bye-bye.